We are game time. Let's go.
All right, let's go. So this is this article was published in NEJM, New England Journal of Medicine, recently this year, and it's about basically antibiotic treatment 7 days versus 14 days in patients who have bloodstream infections. And this was a huge study. So just real quick, let me pull this up. Disclosures. So I am not paid by any company. I am not paid by any antibiotic company. I'm not paid by ACP. I'm not paid by, I actually am paid by Lakeland Regional as a resident, but we are not affiliated to this study at all. And then a disclosure just for AI, there's some images that I was able to make with AI, but none of the data that I'm presenting here is AI generated. This is all from the trial. Oh, I forgot I have to continue adding. Okay, admit. None of the data here is generated by AI. It's all straight from the trial, straight from the PDF I sent you guys, all on NEJM, all online. Okay, so let's start. This study is important because, as you guys know, sepsis is one of the biggest reasons why patients are admitted, it has a high mortality rate. Over 2.9 million people die a year. And the question is, how do you know how long it takes to, control these infections? If you do it for too short of a time, you're worried about not clearing the infection. Obviously, I think that's the biggest worry. So why don't you just give a long extended duration of antibiotics? If you're worried about it not clearing, why don't you just give it for 3 weeks, 4 weeks? Like, who cares, right? Well, you're worried about creating not just harmful effects like nephrotoxic agents. You don't want to give like vancomycin or like zosyn, cefepime for too long. These can also cause damage to our organs. But over time, you get resistance, right? You get increased risk of C. diff and other adverse effects, like I was saying, and costs too. Antibiotics are not all just very cheap. Some are, but just being on prolonged antibiotics can be expensive. And they have looked into this. There's been prior studies. I know there was 3 RCTs in the past, like 5-6 years, that tried to look at this. But for the most part, they excluded patients in the ICU because they're too critically ill. They focused on maybe a narrow type of infection like Pseudomonas only or Enterococcus or intra-abdominal infections versus UTIs. Everything was very specific. There's never really been a huge, broad that captures everybody, or tries to capture everyone with different types of infections, sources, organisms, and multi-center, which is around the country. So this is like the first of its kind. So this was actually a really, really big study, highly critiqued, like very popular in journal clubs. So I thought it was a good one for us to use. And I was going to ask Jessica, what do you think, at least so far, about like under-treating infections versus over-treating? Like, how do you find the right balance, at least from what we try to practice in LRH right now?
Honestly, I personally am a big fan of this study, and we'll talk a little bit more about it as we kind of go through things. But for me, I feel like my physicians tend to pick the 14-day course more than anything, and they're a lot more inclined to treat for longer durations than they are for shorter. And I think it's just kind of how we were taught, how we practice way back when. And a lot of this new stuff that's coming out in the last 5 to 6 years has a lot of emphasis of conversion to oral and using oral agents and not having to go on IV therapy, but also shortening the durations of all types of infections, not just bloodstream. So I honestly think we have a tendency to overtreat things, and my physicians don't always calculate durations based off of what was given in the hospital. And so sometimes the RXs going home are a little bit long, in my opinion. So I do think that this is definitely game changing in that regard. And I of course, obviously there are going to be the limitations, and we have to be more mindful of certain characteristics about our patients and how quickly their sepsis resolves before we decide that we're going to do 7 in all people. But certainly with a trial of this size and the diversity of the patients that it included, it gives us a little bit bigger, more confident leg to stand on.
Yeah. So at least for me, like as a resident, I feel like every time I speak to we work with a million different attendings, and I can ask a different attending the same exact question, pneumonia comes in or whatever it is, a UTI, sepsis, and I can ask them, do we do 7? Do we do 10? Do we do 14? What do you want to do? And I think I could get a different answer from each and every one of them. And the truth is, no one's really wrong right now. There is no true answer. So this is what this study tried to really at least help us hypothesize or let us feel more confident in that decision. So going forward, let's talk about the design. So this was a multi-center study, and it was a huge amount of patients. 3,608 patients is massive. It was randomized, open label, which for those of you that don't know what open label is, it means the person doing the study, or the person, in this case, the physician giving the antibiotics, they know who's in what arm. So they know if you were in the 7-day arm, and they know if you were in the 14-day arm. So that has its weaknesses. Open label for the most part. Some studies you can't avoid it because of design. But in this study, every physician knew, hey, this patient's getting 7-day course of antibiotics. So maybe I have to treat this way. Who knows? Or maybe, or they'll know they have the 14-day antibiotic patient. So that's the problem with open labels, that someone thinks that you might treat with bias. And then it was a non-inferiority RCT. And I have a separate slide on non-inferiority. I remember the first time I saw it, I was super confused by it. So, but it's really important that at the end of this, you guys know that this study is not designed to tell you 7 days is better than 14, or it's not better. It's not to tell you which one is superior to the other. It's designed to just tell you that 7 days is just not inferior, meaning it's not worse than 14, but you cannot say it is superior. So they're basically trying to make you feel, I mean, if their hypothesis is true, they're just trying to make you feel comfortable with the fact that you can give 7 days as opposed to 14, and you shouldn't have any worse outcomes, at least. That's all that's saying. And that's a design. And then I put a picture of like all the countries that they've where they did their studies, but it's important to know that 75% of the studies were actually in Canada. Only 2 were in the United States. They had over, it was like 74 sites, but 75% from Canada, 2 were from USA, 2 were in Israel, and 2 were in Saudi Arabia. Does anybody think that that's okay? You know, when they try to sell you multi-center, randomized, when you think of that, when, you know, they show you all these countries, it looks like it's pretty global, but then you see 75% is from Canada, and really only 2 are in USA, 2 are in Saudi Arabia. You know, that kind of makes you think, well, is it really that generalizable? It sounds big, but you can tell the majority is just in Canada. So that's something to keep in mind. When you think about multi-center, don't just see the word multi-center and think it's fine. You have to see where it was, where each trial was, the percent makeup of each trial. And this is, let me admit, this is another part of their design. So this is complicated too. I'm going to try to make this as easy for you guys as possible. So what they did was, since it's open label, what they wanted to do was they randomized these people who all had bloodstream infections, the participants and the physician blinded. They did not know until day 7. They all got antibiotics, but on day 7 was when they split these patients up into the 7-day group versus 14 days. So they'd get antibiotics no matter what for 7 days, and then they'd split 2 ways. And then that's when the physician knew, all right, this is my 7-day patient, and then this is my 14-day patient. And I personally thought that that design was pretty cool, because even though it's open label, it's still pretty randomized. You still have the 7-day patient who just got that 7 days, you know, there was really no bias there. And then everyone else, you're just going to treat for 14 days. So to me, that design is important, as opposed to from the beginning, if on day 1, you know that they're going to get 7 days of antibiotics versus 14 days, maybe in the 7-day patient, you're going to be more aggressive because you know you only have 7 days to like cleanse this infection, versus 14 days, you know, you might be more conservative. You know, I have time, you know, let me not cause any organ damage. Let me be light on the antibiotics. So I really like that they did that. They actually, it's open label, but they blinded you till day 7. And at that point, you already completed your 7-day course, and you're only treating the other patients for 7 more days. So they did that. And at the end of the 14 days, their study was done. And in 90 days, they looked for their primary outcome, which was all-cause mortality. They wanted to see in 90 days who actually died from this. So non-inferiority margin, I have another slide I'm going to explain about, but they used the 4%. The ITT, this is the modified intention to treat, and the per protocol. So I'm going to make it as simple as possible. These are just 3 different protocols of how you are going to look at these patients. So the intention to treat analysis, you're going to see a lot coming up, especially as you start residency. All it really means is all the patients that you randomize from the beginning, those are the ones you're going to look at regardless of what happened to them. It doesn't matter if they died early. It doesn't matter if, they were lost to follow-up. These are the patients that are going to be included in your study, and the outcome is going to be assessed on them. So it's all of them as a whole. Some researchers don't like that because it can mess up your data. They want to actually look at the patients who are adherent to the medication so they can find the true effect. But then on the other hand, some physicians or researchers say, well, this is not real life. In intention to treat analysis, it's more realistic, it's more pragmatic. Like a lot of patients are lost to follow-up. So that's that. When you use the modified intention to treat, what they do is that they selectively remove some patients just to make it, not to skew your data in any way. So what they did, they just excluded them. If they die before day 7, they're like, all right, we'll take them out. They're gonna mess up our data anyways. So those we won't look at. And then the per protocol is a step even further. Think of it just like as a super modified intention to treat. And for them, it was anybody who, so if they were in a 7-day arm, if they had like 5 days of antibiotics versus 9 days of antibiotics, they were excluded. They didn't want them there because it didn't fit the 7-day antibiotic course. And same thing for 14 days. If they had like 12 days versus 16 days of antibiotics, they were excluded. So it was a very strict one. It was to really get a representation of who fully adhered to the protocol. So again, going from top to bottom, intention to treat is you're including everyone, everybody, no matter what. Then the per protocol is the strict one. These are the people that finished the whole trial, were super adherent to follow-up, and they did the full 7 days versus 14 days. And then the modified intention to treat is just somewhere in the middle. They just really wanted to remove the patients who died before day 7. Does anybody have any questions about this design, or like, do they think anything of, any weaknesses that this design might have or strengths? Does anybody want to pitch into the design?
I agree with you. I really do think that the 7-day blinding at that point was kind of, that's the first time I've ever seen something kind of similar to that. So I did think it certainly is a strength of the study.
Yeah, I think I at least when we did the journal club here at our institution, I had already known this paper, and I didn't even know that they did that. One of our residents, Omar Zudi, he mentioned it, and I was like, oh, that's actually really cool. I think it really strengthened the study. So you go from open label where everyone thinks your study's poor, but it's really not. I think it's open label, but this helps protect the integrity of the study a lot.
And the other thing I was going to say is when it's open label, sometimes it's difficult if it's per physician discretion on what antibiotic you're going to pick, what doses you're going to give, and all the stuff. And each institution, because it was a multi-site, you have different resistance patterns and different antibiograms. So some of the impaired choices would have been different based on your center and your site. And so because all of those variances happen across sites, an open label study is probably the most fitting in that regard because everything is physician discretion. So once again, I thought that was good.
Yeah, I think, and just so everyone knows, in this study, it was all open to the physician. Like they got to choose which antibiotic they wanted to use, whether it was IV or oral. They left it completely up to physician discretion. There's no rules on how you wanted to treat this infection. And like Jessica said, every institution has their own like guidelines or their own, criteria that they follow or protocol. So it was a really nice design in that sense. Okay, this is what I wanted to explain, inferiority. So how do you tell someone, well, it's not better, but it's not worse. It's just non-inferior. So if you look at this, I wonder if my mouse will go over it. Yeah, it will. Okay. So what they looked at was the percent of mortality in their patients. So if you subtract the percent of, let's say the 7-day arm had 10% mortality, and then the 14-day arm had 20% mortality. That difference is 10%. And as if you had a 10% difference, a positive difference, you're going to favor the 7-day. That's the experimental treatment. And that confidence interval cannot pass 0. This will tell you it's superior. So if you had a 10% difference, but the confidence interval was like negative or plus 11 to -1 or vice versa, it crosses 0. So that tells you it's not superior. It cannot be, because there's a chance that they're the same. So it cannot be superior. Now, what non-inferiority does is this line 0, they don't care about 0. They don't care if they're the same or not. They just want to know that they're not that bad. And how they choose this margin, which for them was 4% difference, is based on previous studies. Really, they can honestly pick whatever number they want. But the previous study, the largest, the one before this, was a 10% margin. So they were okay with saying, hey, if I can say with confidence that 7 days is only at worst 4% worse at increasing mortality at 90 days, I'm okay with that. I'm comfortable giving 7-day antibiotics. That's all that this margin explains. And every study is different. Some studies use a 50% margin. It all depends on, what pathology you're looking at. But this study specifically said 4%, and that's a really tight window, just to say, hey, we're comfortable with 4% being off. And that's what this study is. That's all that is. Does anybody have any questions on what that is, or want to have a better explanation? Because I think you need to understand this part to really see what the study's trying to say.
I have a question about it. Is it kind of like a ballpark that they use to go from 10 to 4, or do they have any calculations for that?
Yeah, so they do have a calculation it's very complex, but usually once the first study does it, so the last famous one, I think it was by Yahav, or I forgot his name, but they did 10% through their own calculations. They look at mortality risk. They look at other studies where, 90 days, how many of these patients usually pass away? What's the percentage? And they'll find like averages on what they should be, and then what they're comfortable with after that. So the last one was 10%. They wanted to really be strict and say 4%. Now there is a calculation that, but at the end of the day, it's a ballpark. They can say whatever number they want. They can have all these numbers, but there's no true calculation to tell you, yes, the only way to say this is non-inferior has to be less than 4.37%. There's no way. That doesn't exist. It's just enough for you to feel confident to tell readers, hey, I am confident with telling you that it's non-inferior only if it's not bigger than a 4% difference. So really, that's a good question. That's something that I really sat on and thought, like, how do they come up with this? Like, why? Who gets to make these rules? But it's based on previous studies and some calculations. But at the end of the day, you're right. They do just ballpark it. So if everyone gets that, we can keep on. Okay. One of the key exclusions, they excluded Staph aureus. Does anybody have a problem with that? Does anybody want to know why they excluded Staph aureus?
Yes, I'd like to know why.
Okay, so I honestly don't talk to them, so I don't know why. But does it bother you that they don't have Staph aureus included?
I'm going to tell you why.
Go ahead.
So Staph aureus is very, very tons of virulence factors. It is a very sticky organism. Most patients with Staph aureus bacteremia are going to get 2 weeks minimum, if not more. So even if they don't have confirmed endocarditis, 2 to 4 weeks is the general rule of thumb because of high relapse rates in patients with Staph aureus. So it's definitely something that would not benefit from a shorter duration. And of the gram-positive organisms, should never be treated under 2 weeks. So just keep that in mind. Even if it is only in one set, if it's considered more of a transient, it may have been secondary to thrombophlebitis. If it is Staph aureus, you at minimum have to treat for 2 weeks or longer. So that was actually kind of in line with most of the guidelines. The fungemia is the same thing. It's 2 weeks minimum. And so a lot of these more invasive type infections are all going to be treated for longer.
And that's why we have Jessica Cobian always helping us. Thank you, Jessica.
You're welcome.
And that was Abdul who asked that question.
Oh, yes, that's me.
If anybody else has any questions, feel free to just say your name also so we can get to know you, your full name, if you want, where you're from, whether it's IMG or a resident institution or attending. At least we can put some type of image to you, okay? But thank you for the question.
I have a question.
Yeah.
Well, I guess maybe it could have waited until the end, but it's more of an ethical question about this. Hi, sorry, my name is Sammy. I'm an incoming resident at UCF. My question is, if the general guidelines, if generally patients are treated, patients with bacteremia, non-Staph aureus bacteremia are treated with 14 days, ethically, how are we allowed to, try out giving out a 7-day course for some patients and see what happens? Wouldn't that risk, mortality for the patient? Well, now we know there's not a difference for it, but when we're designing the study, how do we ethically approach this?
I think a lot of the trials that had been done in the past were also retrospective in nature and gave us some information about treating our patients. Because if a patient's clinically stable and people start to explore shorter durations, that sort of becomes the hypothesis for the next large study. So I think it's just been an evolution of time, but a lot of the guidelines you'll look at will give you ranges, 7 to 14, 7 to 10, there's always a range. And so then people are always asking you, well, 7 to 14 is a big range. That's a week versus 2. So how is it that we pick which range to stick with? And that's why there's so many trials trying to look at the comparison of 7 to 14, because when you give me a range, how do I pick what duration and why? And so I think this is kind of assisting us and helping us in kind of being more steadfast on what we are selecting.
Yeah, so Sami, just to add to that, I don't know, am I saying your name right, Sammy?
Yeah, that's fine.
So, no, it's a good question. So one thing to know with RCTs or big trials like this, never do these people just come up with this study like, hey, this sounds like a super good study. Let me just do it, because there are a lot of ethical considerations. These things come from a bunch of retrospects, small little studies from little places that start picking up traction. And there was we did a meta-analysis on this sort of here at our institution. We found 20 studies. Most of them were retrospects, like 3 RCTs that were very small, and they all started like this. Then non-inferiority, they start saying that 7 days is actually non-inferior. So then you take this to that IRB and you say, hey, we're getting an increasing amount of data, and stuff that 7 days is not that bad. I think this is a decent hypothesis to test, and that's it. That's all you need, IRB approval. And that's how these things get going. But they usually start with retrospects and small little observational studies where you look in the past and whatnot. So that's a really good question.
Awesome. Thank you, guys.
Okay. Another thing I want you guys to look at here, so the makeup of this study. If you notice, 61% of all the patients here that had bloodstream infections, the source was either UTI or intra-abdominal. And 71% of the organisms were gram-negative. Does this bother anyone with the generalizability of this study? Because I think for me, the most important thing is, the majority of your UTIs and intra-abdominal infections are usually gram-negative, and we're talking about 7/10 of this study is all gram-negative. But gram-positive infections are very common too. You can have, skin infections, lung infections, other sources where you have gram-positive bacteria. So I think this was a really overwhelming, not design, but population of the study for it to be mainly gram-negative. And I'm sure removing Staph aureus also hurts this, but Jessica explained why. But the source, urinary tract and abdomen, does this, do you think anything of it? Do you think it changes anything?
I mean, I do think that it was the first stab at trying to take a closer look at gram-positives mixed with gram-negatives. So although it is predominantly a gram-negative study, you did take into consideration some other gram positives that we do see. Enterococcus is something that we frequently see in the hospital. So I did like the attempt at including more rather than just gram, because urosepsis, I mean, a majority of the previous trials you had already mentioned were only gram negative, were only enterobacterialis. And so I do think that they did a great job of really trying to be more inclusive, because you're right. Once you remove Staph aureus, then what other gram positives do we have? Strep and enterococcus. It doesn't leave for much.
Yeah.
So yeah, but I mean, of course, abdominal and your urine sources are going to be the highest frequent that we see in the hospital anyway. That's the majority of my day.
Yeah. And I was going to ask you, Jessica, I know I had asked you this previously. Do you think, I mean, I'm not an ID expert, but do you think the source of your bacteremia, where like organ wise, do you think that matters at all as far as how complicated to clear your bacteremia is?
It does, which is also kind of going hand in hand with why we don't repeat blood cultures in gram-negative sepsis, because gram-negative sepsis typically is something that is cleared, especially from a urinary source, within 24 hours or less after your first dose of active antibiotics. So it is definitely something that would warrant a 7-day duration, especially if you turned the corner quickly, because you cleared the bloodstream quickly. It didn't go anywhere else. It didn't seed anywhere else in the body. And so, yeah, source does matter.
Yeah.
And it mentioned in the trial that source control was provided in certain amount of cases. You're not going to do source control in a urine tract infection because you've already cleared the source by penetrating the urine. But when it comes to abdomen, you need source control or whatever the case may be. And that matters too.
Yeah. Okay, so we have that in mind now. Now we can look at their outcomes. So this was actually the really cool part. They actually looked at the 90-day mortality, and they saw that in the 7-day group, they had a 14.5% versus in the 90-day in the 14-day, they had 16.1%. So if you look at if you look at this confidence interval for all three, so they looked at the intention to treat, which is they included every single patient, the per protocol, which is when they removed patients who died within the 7 days, which was more strict. And then the strictest one, modified intention to treat was the second strictest one. This is when they removed if they died within the 7 days. And the per protocol was if they were +2 over or under 7 days or 14 days. And all three, so this is your 0, this tells you that it's not superior to 14 days because the confidence interval, which is here, -4 to 0.8 to 0.6, it goes past 0. So it tells you that there's a 95% chance that it is not superior. And for that reason, it's not. That's how we do forest plots. But if we look at their 4% margin, so this tells you that as long as there's a 95% certainty, which is what a confidence interval is, that I do not have a worse 4% mortality rate than the 14-day of antibiotic course, then I can say it is non-inferior. That's all that means, non-inferior, not better, not superior, it's just not worse. So, and in all three arms, when you keep all the patients, when you remove some who die early, or when you remove some who don't respect the actual antibiotic duration, it was non-inferior in all three and pretty similar. I'm not going to say it was close to superior because that's not scientifically correct to say, but it was non-inferior. So this is the most important outcome. And then we're going to go over some secondary outcomes that might be important. So looking at the length of stay. So in reality, so I know the first thing that confused me and something that I critiqued my colleagues, but I didn't understand at the time. I told them, well, how do you have a length of stay of 10 and a length of stay of 11 for a 7-day group versus 14-day group? It doesn't make sense. Like, the point is to have 7 days of antibiotics. It has nothing to do with that. They stopped antibiotics at 7 days, but they, for discharge reasons, some had, social work stuff pending. They finished antibiotics, but they weren't medically cleared to be discharged away. And likewise, in the 14-day group, maybe they finished antibiotics, but at home, It doesn't say in the protocol that they couldn't be in the hospital. In fact, it was all physician discretion. So in these 14-day groups, it's very rare for you to receive 14 days of antibiotics inpatient unless you're really, really sick. And they did include ICU patients, but these patients were discharged around 11 days, and then they finished their 14-day course. So this outcome tells me that just in knowing, just in physician discretion, just knowing that you have a 7-day group and a 14-day group, you discharge these patients a day earlier. That was significant. And I thought that was pretty cool because if you just knowing that you're eliminating costs, an extra day of being in the hospital, getting hospital acquired infections, just with knowing, just having psychologically in your head that that's a 7-day group versus a 14-day group. Because just being a 14-day group doesn't mean you had to stay there 14 days. They could still discharge you just the same, but they have to give you oral antibiotics outpatient. So I thought that was important. Other than that, there was really nothing that caught my attention. Hospital mortality, that means when they died in the hospital, there was no difference. The length of stay in the ICU didn't change at all. If they had to use vasopressors or not, didn't change. Intubation rates, nothing. And the most important thing was C. diff infection rates. They didn't decrease at all. So that was one of the worries about, we're going to overtreat with antibiotics 14 days versus 7 days. But in these patients, there was no difference in C. diff rates. And I wanted to ask Jessica, how do you feel about that? It's a full 7 days extra of antibiotics. And I feel like in LRH, or at least in where I'm practicing, we get so caught up, with C. diff, we're causing C. diff, we're giving antibiotics for too long. But there was no difference in these patients at all from 7 to 14 days. What do you make of that?
Yeah, that's tough. That's a tough. C. diff is such a it's a part of a secondary outcome of almost all ID studies where you're trying to show that if you decrease or you increase your antibiotic-free days, of course, less exposure, you're not going to alter the gut flora that much. You obviously want to show that C. diff was less likely to happen, but it fails me every time,
That's something that I saw, because that's a big argument for like the 7-14 days. It's that, like, C. diff. I know that was one of the main things in their introduction. And when I saw no difference, I was like, wow, 7 days extra of antibiotics and there was no difference. So that's comforting for the 7-day group now. Now they're just not showing that it's non-inferior, but now they're saying, well, there's no difference in C. diff either. You don't have to, the 14 days, it goes against it now. Like the 14-day people are saying, well, we're not going to cause C. diff giving you 14 days. So we're the same, not inferior to each other, but we're not going to give you C. diff. And that was, one of the worries. If it showed that there was C. diff difference or a benefit in the 7-day group, I think more people would be very comfortable doing the 7 days going forward. But I think this was a very interesting secondary outcome that I know I got a lot of critique on. So,
and keep in mind that because it's a subgroup analysis and because it is in that smaller range, it's not to say that if you were looking solely at C. diff rates and you had a higher sample size and you were powered in that particular aspect, that you could see a difference. Obviously, it would take a lot more patients and maybe a little bit longer time period to then follow up and see if it had any effect there. But yes, I agree with you.
Does anybody have any questions on these outcomes on the primary one, or do we understand that and the secondary outcome, what we're looking at here? Okay. The subgroup analysis. All right, I think this was a really cool part of their study. Just so you guys know, this was not powered to have any type of real significance. So what that means was a subgroup analysis, though, basically, it only works for the primary outcome, which was 90-day mortality, and they look at specific portions of their population. So for them, they looked at source, whether they were in ICU or wards, how clinically sick they were, and they want to see specifically, is there a difference in, did it benefit these people in any type of way more than others? All these are meant to do is create hypothesis, just like Sammy asked from USF. How do they just start these RCTs? Like, are they ethical? Well, it starts with things like this, like subgroup analysis. Like, they can see, well, it's showing that, people with, lung infections, actually 7 days was inferior. It's not powered to prove that, but now you have a hypothesis. Now you can go to IRB and say, Well, the balance trial said that in lung infections with bacteremia, 7 days is not good. It's inferior. So, I want to do an RCT on this. This is how you just start hypothesizing things. And I want to go over some things. I don't know. Can you guys see the subgroup analysis well, or do you see it blurry?
I see it well. It's just kind of small.
Yeah, it was hard to fit completely, but I can go over the main things, which, and again, you cannot take any of this with, you cannot say it's true or statistically significant. This is all just to draw some hypothesis. So the two scores, the clinical frailty score, I'm not going to go deep into it, but it's basically just to assess how physically fit they are. They wanted to see if in patients that were not frail, are actually fit, which is less than 5, if they benefited in any way. And only in patients that were, mildly frail, at worst, did they have a non-inferiority. So patients that are very frail, not fit, the 7-day course was not good for them, or it was inferior. But again, we cannot draw these conclusions. It's just hypothesis. Same thing with the Apache 2 score. It's a way to assess mortality, mortality risk. So they looked at patients with a score less than 25, very similar to clinical frailty score. In summary, it really only in patients that are not too sick, they're actually fit. These actually benefited from the 7-day course in theory. And then we see in gram negative, I thought this was pretty cool. So in gram negatives versus gram positives. So in gram negatives, it was actually, again, we can't say this, but it was superior to the 14-day course. You can't take that with a face card because it's not powered, but in gram positives, it wasn't even, it was not non-inferior. So I wanted to ask, what does anyone think anything of that? Any hypothesis they can draw from that? Like, why is there such a difference between gram negative and gram positive? And we're not talking about Staph aureus, like Jessica mentioned. And she alluded to that earlier, but if no one wants to answer, Jessica can maybe shed some light on that.
Yeah, I thought that the gram negative, it was just very telling. I mean, it's very markedly in favor of this is, and just, I already said it, you clear your bloodstream pretty quickly, especially if 70% or whatever it was, 60% were coming from the urine and abdominal sources with adequate source control. You're going to do well. You're going to be fine. Give them 7 days.
Yeah.
I mean, so
Yeah.
If anything, it's just like giving me more and more kind of ammunition to kind of favor that in those patients. And of course, this was a high percentage of ICU at enrollment. When what was it, 45, 50, I forget the exact percentage, were enrolled in the ICU. So even if you made it to the ICU and you quickly de-escalated to a lower level of care within 48 hours, you still did fine and you still got 7 days and did okay.
Yeah. No, it's actually really interesting. And in these patients, so also we could just go to the bottom one. The ICU patients even had a benefit, or they were non-inferior as well, which was this is what gave the study a lot of hype. The fact that they included ICU patients and that they were specifically, when they looked at them alone, not just combined, alone, it still showed that they were non-inferior. Again, this is just a subgroup analysis, but it is very telling. Interestingly, though, to play devil's advocate, those that were on vasopressors did not have that same benefit. And it's kind of hard to say, like, well, if a patient's in the ICU for sepsis, aren't they basically on pressors? Why else would they be in the ICU? At least that was one of my critiques when I had my journal club. It was something that I thought of. How can you be in the ICU for sepsis? You're not, you're probably not intubated. And you're not on pressure. So why are you in the ICU? So that was the only odd thing, the fact that there was that difference in ICU and vasopressors. But does anybody else think anything about that? I could be wrong.
Yeah, a lot of my ICUs that are there with infections, bacteremias, DKA is a big indication because you need the insulin drip in the ICU. So a lot of my DKAers go there. You know, if their blood pressure is soft and they're not on vaso, but they need a little bit more monitoring, sometimes they'll go directly there from the ER. So, you know, but the biggest thing that I thought of was definitely DKAers. It came to mind.
So what if I get a patient who gets admitted, urosepsis, I have a clean UTI source, but they're in septic shock and on pressors. Are you comfortable doing 7 days or 14 days?
That's kind of what, so I was looking at another journal club kind of overview, and they were just saying, like, you need to assess your patient at about day 3, because that's kind of where because a lot of people that are started in the pressors in the ED and they end up getting transferred to the ICU and they put off that norepi in about 3 or 4 hours.
Yeah.
That technically is a vasopressor candidate. And they quickly weaned them off, and they resuscitated, they were dehydrated, they now got fluid, you know, all the things, but they quickly turned the corner and now they're back on the wards. That's still somebody I think would be considerable where you could do 7 days as well.
Yeah.
Go ahead.
No, I think the worry might be, at least when I've been in ICU, maybe some attendings are like, you know, what I have to lose just giving at least an extra 3 days or you know, an extra 7 days, you know. I think that's like a fear, and it's something that'll come with time as more studies come. Maybe people will feel more comfortable. But I know that's always just because you're in the ICU automatically, I feel like everyone has that fear, like 7 days, it's pretty scary to just cut it like that. But yeah, I think this subgroup analysis was super interesting. They also mentioned that men had a benefit and not women. That's when I start to think, okay, I don't know, like this is definitely not powered for a subgroup analysis, because where did
you see the men? I lost that. I didn't see that part.
Is it, do you see it in the actual, let me pull up the PDF to make sure I'm not making this up.
It's okay. I didn't, yeah, I don't think sex plays a difference. If you got urosepsis, male, female, etc., I'm not really sure that in that regard, sex plays a role, and how you clinically respond. I think the elderly, I don't know.
Yeah, I didn't think so. Yeah, this thing's not pulling up, but yeah, either way, I don't think that's a thing regardless. But that's a subgroup analysis. I'm sure many things will come up after this. Just based off this, the lung infections not being a thing. I remember I asked you what you thought of that. But again, none of these things are powered they're just designed to make you think a little bit. But we're just a minute over, so we can just really quick, let's talk about the strengths. Big study. We're very good at doing a one-to-one randomization. We talked about how it's open label, but they did the 7 day, they randomized after the 7 days, kind of like a hybrid, which to me, that this is not an open label study, but they have to call it that. I think they did really well. They were very gutsy in doing the narrow 4% margin. That's very tight window, you know, and they actually hit on that. So a lot of props to these people. And I like that they did the modified intention to treat and the per protocol. They included all 3 types. So they didn't leave anything open to critique. They said, well, we included even the people that died within 7 days. And we even included people that were off the 7 day mark by 2 or plus or minus days. You know, we had all 3 of those pools of patients, and in all 3, we still showed consistent, you know, results. And that is really, it strengthened the study a lot. As far as weaknesses go, so the fact that 3/4 of your patients are from Canada, you only had 2 sites in the USA, you know, it's kind of, you know, is it really generalizable? Was it really multi-center and global? We talked about the subgroups, which, you know, there was a lot of discussion about them in other journal clubs and other meetings. But again, the important thing to know is that it wasn't powered to say anything. This is all just to create hypothesis. The biggest critique for me was, you know, the heavy UTI and gram-negative bias. I think gram-negatives made up like 71%, and UTIs in total were like 61%. And like Jessica was saying, these are easily clearable. You can feel really comfortable doing 7 days of treatment. So did this skew, you know, the study into saying 7 days is non-inferior? We don't know. And then the subgroup analysis didn't help because it wasn't powered to show us if UTI versus no UTI, if there was a difference. So that for me is the heaviest critique, and I'm sure RCTs after this will find ways to clear that up. And then the Hawthorne effect, basically the fact that it was open label every day after 7 days, they had to see these patients, change management, see if they had to, source control, whatever it is, and it might have made them stick to guidelines more. Maybe they thought they were, their clinic is under, watch, whatever it is. So it would have made it not realistic, where in the outpatient setting, maybe people would just continue the same antibiotics for 7 days and see what happens. That was the only real weakness, but overall, this was one of the biggest studies. I mean, really powerful study. I really enjoyed this study a lot. In conclusion, 7-day antibiotic therapy was non-inferior to 14-day antibiotic therapy with respect to 90-day mortality. That's all we can say. That's the only conclusion we can take from this study. It's not telling you to pick one or the other. Remember that. Don't go to your attendings tomorrow and say, hey, this resident from LRH told me to do this. I'm throwing down 7 days of antibiotics on everybody. That's not what I said. This is just a non-inferior study. So, and it's specifically take into account this is mainly urosepsis, gram-negative bacteria that was non-inferior. Okay. Does anybody, Jessica, do you have any comments on like this conclusion or the study?
Yeah, I think it's a very powerful study. It was one of the best done or clinically, designed. And I do agree that, of course, with your conclusion in that, you have to obviously care for your patient and decide and determine what the duration is. But I do think two closing ideas. I think we could use biomarkers a bit more. I know one of the trials from a couple years back did the CRP guided.
CRP guided.
Yep. I'm a big fan. I know that there's limitations and that's an additional lab draw and stuff like that, but procalcitonin the same way, with an 85% reduction, it's something that we can couple with the patient clinical response to kind of help us sway 7 versus 14 and kind of show us systemically what that patient's biomarkers are doing. So I do think that that's something that we can do more, especially in the uroseptic patient. But also, if we are going to be doing more of the 7 days, I'm trying to think of, okay, one less social work consult, less pick lines, more, because if my average length of stay is 5 to 7 days in the, uroseptic patient that's turning the corner quickly, a lot of times we're hanging around because we've got to submit for insurance and we have to submit for approval for IV antibiotics if there's no oral conversion options. There is a lot of cumbersome things that adds on to a patient care when you have a 14-day duration compared to 7. 7, easy peasy. All right. So there is a lot more from a logistical standpoint that is very favorable from a shorter duration.
Yeah, I think at least for me going forward, it's something, I mean, I'm just a resident but it's something that I'll start, trying to push at least when I'm on rounds, always, at least in urosepsis patients that are were bacteremic, I think 7 days is something, I'd be looking into, I'd be trying to push. But definitely more studies need to come from this. But I just want to thank you, Jessica, for coming out here, helping me out, laying down some knowledge on this. I know you're our big expert on ID stuff. I want to thank everyone for coming to the first journal club. I want to thank Sammy. I remember some of the names, Abdul, Devesh, all you guys for pitching in. I want this to become something where we can come and talk, even argue if you want about some of the research here, give different opinions, what you do at your institution, and we can collab on things. If you want to do like follow-up retrospects, cross-institutional or even meta-analysis on things, this is what I want this to become, like us to talk, start a chat off this and say what you do different, what we can do different. And we can meet each other and, have research going just off of this. So thank you guys for everything. And don't forget the QR code there. Oh, I hear you, Dr. Bizanti. You have something to say? You're muted. If you guys can, just scan the QR code. Any feedback helps. It's anonymous. You don't have to answer everything. Just let me know what study you want to see next time, who you want me to bring, anything you guys need.
Are you able to hear me now?
Yes.
Yeah, so Thank you very much, Dr. Sabina, and thank you everyone for joining today. This was great, and I just loved how you just put the flow, just the format of how is the journal club is actually should be done, and going through all of those formats. This was just an amazing discussion, very intriguing. My just 2 cents for this. This was an amazing study, very well designed. I'm too late to the party to add a lot of it, but a lot into this. But here, I think you and Jessica have did an amazing discussion here. And just to the question of Sammy with the 7 days versus 14, actually, my new question is why not 5? Why not 3 days? And I think this was the new studies should be actually aiming for. The only weakness that they had, which is actual real life, 23% of the patients on the 7-day trial, they did extend it further. They initially intended to treat for 7 days, then they went further, and that did make it up. But I think amazing job, just the structure that you have done, and everyone who want to do journal club, not just for the knowledge from this study, but just how did you guys dive deep into exclusion, inclusion, a little bit of knowledge nuggets into what's the intention to treat. This was amazing, well done, and thank you everyone for organizing and making this happen. Back to you, Sabine.
Thank you, Dr. Bizanti. And seriously, thank you to everyone who came. This is the first of many. We're going to have
I
two
think
more.
Dr. Lugo have his hand raised, if not mistaken.
Okay, yeah, Dr. Lugo, that's my program director. You can speak. Feel free to interrupt.
Oh no! Oh well, Dr. Besanti kicked in. I really enjoyed hearing this. I was gonna ask Dr. Besanti, how do I introduce this if I want to say this and during rounds, and I want to bring this up to my attending. How do I bring this up if I wanna try it out so that I can make Dr. Besanti proud?
Dr. Sabina, you give it the try, and I will tell you if you succeeded or not. If you attempted this in my rounds, how would you bring it up?
I think Dr. Bizanti would probably say, "Are you sure you want to do that?" And if you reference the trial, he's gonna say, "All right, if the patient goes bad, it's on you, but let's do it." But Dr. Bizanti is very open to. I think as long as you mention stuff, you give some good evidence. I think attendees should be open to it. I know that Dr. Bizanti is one of the ones that's always open to things like this.
Yeah, I think a way, if I was a resident trying to bring it to an attending, whether open or not, I'm like, hey, doc, I just heard about this new trial where they are giving patients only stopping antibiotic after 7 days. I think this patient might fit into the same inclusion criteria that they have. Would you mind taking a look and let me know if he would fit and this new guidelines might fit for him? So that's something how you're intriguing and you're making your attending eager to go and look into this. So and might adopt this new practice. But to answer your question, the last comment that you have, the conclusion, would you adopt this? I think I would adopt it in a lot of my patients. 7 days. I think Jessica and all the ID team will be happy and proud of me if I stop antibiotic early. So everyone wants antibiotic stewardship. That will definitely be great. Again, sometimes you have to extend it, but I think I would adopt this in my practice.
Yeah. Thank you, Dr. Bizanti. So again, thank you guys for everything. Just scan that QR code. We're going to remember next week we have the workshop. We're going to talk about case reports, how to get those things published. And I want to hear your feedback on the next journal club, whatever you guys want me to do. We'll talk about who do you want me to bring, any specialists, and hopefully it's as informative as this one. So thank you everyone for having me, and I hope we continue to grow. Thank you, Dr. Bizanti, for the support, Dr. Lugo, everyone from LRH. Jessica, you are my rock. Thank you.
You're so welcome. You did awesome. Thank you, guys.
All right. Bye.
Bye.